Hello, StudyNurseIQ family. Welcome back to the channel. I'm Jenny, and today we're breaking down one of those confusing but high-yield topics every nursing student needs to master: SIADH versus diabetes insipidus. If you've ever mixed these two up, you are definitely not alone. One's about holding on to too much water, the other's about losing too much water. But once you understand one tiny hormone, everything will start to make sense. In this video, we're going to keep it simple. We'll talk about what causes each condition, their opposite signs and symptoms, and the key nursing interventions you'll need for exams and real patients. Stick with me till the end, because we'll finish with NCLEX-style quiz questions to test your knowledge and help you lock it all in. Before we dive in, you'll hear me say SIADH and DI a lot in this video. Just so we're clear, SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone, and DI stands for Diabetes Insipidus. I'll use the abbreviations to keep things flowing, but remember, that's what they mean every time you hear them. All right, let's get started. The key player, antidiuretic hormone, ADH. The key player in these two conditions is the antidiuretic hormone, or ADH, which is also called vasopressin. This hormone plays a huge role in SIADH and diabetes insipidus, where it acts in completely opposite ways. In SIADH, you have an increase in ADH, and in diabetes insipidus, you have a decrease. So what is the function of ADH normally? ADH plays a major role in regulating the amount of water in the body, essentially acting as your body's water retainer. It keeps your body nicely balanced with its fluid levels, and it also constricts blood vessels. How does it accomplish this? It works directly on the kidneys. Specifically, ADH causes the renal tubules in the kidneys to retain water whenever it is released. So if you have a lot of ADH, you keep water. If you don't have enough ADH, the kidneys are going to say, hey, let's just get rid of this, and you'll lose too much. Now let's quickly talk about where ADH comes from in the brain. The hypothalamus is responsible for producing the antidiuretic hormone. Right below the hypothalamus is the posterior pituitary gland, which is responsible for storing the ADH and secreting it into the bloodstream. Make sure you commit that to memory. Hypothalamus produces it, posterior pituitary gland stores and secretes it. SIADH, the water hoarder. The acronym SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. A great way to remember the key mechanism is to look at the letter I in SIADH, which you can use to remember increase ADH. When you have too much ADH, you retain too much water, leading to water intoxication and fluid overload. Causes of SIADH. The antidiuretic hormone is being oversecreted, usually because the hypothalamus has been damaged or the ADH is being produced somewhere else in the body. Lung cancer. This is a #1 cause. Small cell lung cancer can actually cause the hormone to be overproduced. SIADH can be one of the first signs of this cancer. Damage to the hypothalamus or posterior pituitary gland, which are responsible for ADH regulation. Infections, such as pneumonia in the lung or meningitis in the nervous system or Guillain-Barré syndrome. Medications. Some drugs like chlorpropamide, diabetes, can have properties that increase ADH. Signs and symptoms of SIADH. Because the patient is retaining too much water, they will present with fluid overload. You will see edema and dramatic weight gain. They will have high blood pressure hypertension because of all that extra fluid volume. Lab work will show hyponatremia, a low sodium level. This is called dilutional hyponatremia, where the sodium has been diluted by all the extra conserved water. Because the brain tissue is very sensitive to extra water, you will see confusion, lethargy, and a high risk for seizures due to brain swelling. They will have a low urine output because the kidneys are holding on to that water. The little urine they do put out will be very concentrated, meaning they will have a high urinary specific gravity. Diabetes insipidus, the water waster. DI is the opposite of SIADH. The patient has a decrease in ADH, leading to massive fluid loss and dehydration. Causes of diabetes insipidus. Diabetes insipidus is usually caused by an issue in one of two places. There has been trauma or damage to the hypothalamus or the posterior pituitary gland, so ADH is not being produced or secreted appropriately. The kidneys, nephrogenic D. The kidneys are not receptive or sensitive to the ADH that is there. Medications. A drug called diclomycin, which is actually a treatment for SIADH, inhibits ADH and can cause diabetes insipidus if not carefully managed. Gestational diabetes insipidus. This happens during pregnancy when the placenta produces too much of an enzyme that breaks down ADH. Signs and symptoms of diabetes insipidus. Because the patient is losing massive amounts of water, they will be severely dehydrated. They will have a high urine output, polyuria. Patients can urinate anywhere from 4 liters to 24 liters of fluid a day, which is a lot of fluid. To compensate, they will have extreme thirst, polydipsia. They will literally crave water and ice. You will see signs of dehydration, dry mucous membranes, and poor skin turgor. They will have low blood pressure, hypotension, because they have urinated out all their fluid volume. Their urine will be very diluted, meaning they will have a low urinary specific gravity. Lab work will show hypernatremia, a high sodium level. All the water is gone, leaving the sodium behind in a high concentration. Nursing management and treatment. General interventions. For both SIADH and diabetes insipidus, you need to get daily weights. This is the most accurate way to monitor fluid status. Watch intake and output, INOs, strictly. Implement safety precautions due to the confusion caused by electrolyte or water imbalances. SIAH medical treatment, goal: remove fluid. The goal is to remove the excess fluid and sodium. Fluid restriction. This is a crucial nursing intervention. The patient must adhere to the doctor's ordered fluid limit. Loop diuretics, example furosemide or Lasix. These medications promote diuresis, urination. Watch out for hypokalemia, low potassium, as loop diuretics waste potassium. Hypertonic intravenous IV solution, example 3% saline. This is used for severe low sodium. It draws water out of the swollen cells to be urinated out. Watch out for worsening fluid overload or congestive heart failure. Diclomycin. This drug inhibits ADH. Remember, this is in the tetracycline family, so do not give this with calcium-containing foods like milk or antacids, as it affects drug absorption. Diabetes insipidus medical treatment. Goal: replace DH and fluid. The goal is to replace the missing ADH and the lost fluid. A DH replacement, desmopressin, DDAVP. This is a synthetic form of ADH. When administering this, the nurse must watch for signs of SIADH, which means watching for water intoxication and a resulting low sodium level, hyponatremia. Chlorpropamide, diabetes. This is sometimes used for mild cases of diabetes insipidus. Watch out for hypoglycemia, low blood sugar, as this is a diabetic drug. Also, it causes the skin to be photosensitive, so patients need to cover up outside. No diuretics. As the nurse, make sure the patient is not consuming products that promote natural diuresis, like caffeine, coffees, and teas. All right, it is quiz time. Let's test your knowledge on the key concepts. Question 1. Which of the following is an expected finding in a patient diagnosed with SIADH? A. Serum sodium of 148 μQ per L. B. Urine-specific gravity of 1.002 C. Dilutional hyponatremia. D. High urine output. The correct answer is C. Dilutional hyponatremia. Rationale. SIADH causes water retention, which dilutes the sodium concentration in the blood, resulting in a low sodium level. Question 2. The nurse is caring for a patient with diabetes insipidus. Which nursing intervention is the most appropriate? A. Place the patient on a strict fluid restriction. B. Administering intravenous hypertonic saline. C. Providing intravenous fluids and encouraging the patient to drink water. D. Administering diclomycin every 6 hours. The correct answer is C. Providing intravenous fluids and encouraging the patient to drink water. Rationale. Diabetes insipidus causes severe dehydration and polyuria. The goal is fluid replacement and oral hydration to correct the deficit. Question 3. The nurse prepares to administer desmopressin, DDAVP, to a patient with DI. The nurse knows that the most critical complication to monitor for is A. Hyperkalemia and severe diarrhea. B. Signs of water intoxication and hyponatremia. C. Profound hypoglycemia. D. Hypertension and severe headache. The correct answer is B. Signs of water intoxication and hyponatremia. Rationale: desmopressin is ADH replacement. If too much is given, the patient retains excessive water, causing water intoxication and a resulting low sodium level. I hope you found this breakdown of SIADH and diabetes insipidus to be helpful and that you now understand that these two conditions are complete opposites. If this video was of value or added value to you, please head to our YouTube channel StudyNurseIQ and click subscribe. I'm Jenny, and I'll see you in the next video.